Now share. Okay. Okay, we talked about this already in the class. Now we did the CNS and now the PNS. Mostly we're going to have a lot of this, especially for the motor, is going to be the autonomic nervous system. As far as the PNS, we're going to have some motor going to the skeletal muscles. We're going to have sensory, but the sensory is going to be both somatic and the visceral. Sensor types, how they classify by what they're detecting. Is it a heat sensor? Is it a cold receptor? Is it pain, pressure? What are we trying to detect? We also classify it by where they're really looking at. Is this something that's monitoring something going on inside of us, or is it something outside? They call those exteroceptors and interoceptors for inside. And the last thing they do is they classify them by how complicated they are. We talked about the skin, have all those sensors. Well, those are just really super simple. Just one cell, basically, just that one neuron. But then you get something like the eyes and the ears and all of this, and it gets to be much more complicated. As far as the sensor types, mechanoreceptors are going to be the pressure, thermoceptors, heat and cold, photoreceptors, that's in the eye. The chemoreceptors, that's going to basically be inside our body, but it does also go with the sense of smell and the sense of taste. And this is everybody's favorite, the nociceptors. Those are the guys that send pain signals to the brain. Exteroceptors, interoceptors. This is the one I kind of made mention of. Proprioceptors, they're going to be stretch receptors inside the skeletal muscle, and some are going to be inside the tendons. And they just kind of let us know how stretched our muscles are. Free nerve endings like the temperature and the pain, the encapsulated are almost always going to be mechanoreceptors, pressure receptors. Let's go. We talked about that. That's the two big types. Merkel disc and the hair receptors that are around the shaft of the hair. Free nerve endings, this is the same thing, it's just a better picture. And these are almost all going to be for pressure. There's that lamellar, which is for deep. Tactile, especially the ones that are up close to the border of the dermis and epidermis. There's that muscle spindle that's just for stretch. And then that tendon organ, which is going to, I don't know why I got a hard on that, but okay, is going to be for stretch on the tendons. Okay. Sensory integration just means interpreting the incoming signals. Sensation is what happens at those little receptors in the skin or inside. Perception is what happens inside the somatosensory cortex. It's going to be the guy that's going to determine what this is. And once we decide what it is, then we'll make a decision on what we're going to do about it. If it's an itch, we're going to scratch it. receptor level, that's going to be the sensory receptors. Think of those nerve endings, those free nerve endings in the skin that are hot or cold. Circuit level, that's what happens when it gets inside the spine and starts going up. And in the perceptual level, that's where we actually decide what it is and what we're going to do about it. Here's another one of those terms that they like. Transduction just means changing something from one thing into another. Most folks have tire pressure sensors in their tires nowadays. So those pressure sensors in your tire are going to take the pressure and change it into an electrical signal that comes up on your dash. The same way that we take something like cold from the surface of the skin and we're going to change it into a nervous impulse, an action potential. That's all transduction is. Yep. The receptor, like in the finger there, the circuit coming up here and including the thalamus, which is the guy that's going to send it to the right part of the post-central gyrus to let us know exactly where it is and all of this. This is just basically the same thing, just showing the circuit level from the spine all the way up to the thalamus. Adaptation, we talked about that when we were talking about muting our senses when there are things that are not important. Most of our sensation is going to be this phasic. Oh, come on now, I don't need this weird stuff. Oh well, don't matter what I want. Phasic, those are the guys that once they send a message to the brain and the brain doesn't care, they basically stop. They've got nothing else to say. Tonic receptors, these guys don't adapt. And that's going to be the pain receptors. Your pain receptors, no matter how much you don't pay attention to them, are not going to stop sending that signal. But then again, they're trying to keep us from, having great injury. But as long as whatever's causing the pain is there, these guys, they're going to just keep sending it until it stops. These phasic receptors, once they've done it, then they're just going to cease. Circuit level. Okay, let me go ahead. So there's the dorsal root ganglion. There's the neuron in the posterior horn. And there's a neuron in the thalamus. This is the first order neuron right there. That's the second order neuron. And the one in the thalamus is the third order neuron. These are the guys who just process it. We've already seen that before. And we talked about that the somatosensory cortex will use that association area to help it pattern match what's going on. That's the same thing. Okay, going back to pain, histamine, potassium. A whole lot of potassium shouldn't be outside our cells unless the cells are damaged. ATP, acids, bradykinins are going to be one of the guys that are going to help trigger this. As far as the pain signal inside the system, glutamate, and especially this guy, substance P, he's the guy that's going to send that. That's a neurotransmitter to that second order neuron in the spine. Visceral and referred pain. We talked about that. We talked about how people with a heart attack often feel pain in their left arm, even though the heart is over there. But the problem is that the visceral nerves are going to travel with the somatic nerves from the left arm, so the brain is going to misinterpret it as being there. And that's all referred pain is. There's only, you just really have to kind of memorize this when you get on the floor, but you don't need it right now. So gallbladder pain is going to be right up there at the right shoulder. The heart, you can see it going down the left side. Liver pain can feel all the way up in the chest. The appendix is kind of interesting. It actually starts right around the umbilicus and it gradually migrates until it actually centers over where the appendix is. But you can see that all these areas, there, it's just the pain, the problem isn't in that area, but that's just where the brain is misinterpreting. I think we talked about this, and at least in the lab. Epineurium covers an entire nerve. Nerves have fascicles just like the muscles did, and they have a perineurium. And each individual axon has a connective tissue sheath over it, and that's going to be the endoneurium. Functional types. Some nerves are purely sensory. Some nerves are supposed to be purely motor, but in a lot of cases, they also have sensory stuff coming from the muscle tendons, the tendon organs, and the muscle spindles. But the sympathetic, though, tends to be more pure motor. Most of our nerves are going to have sensory and motor. So you're going to have some axons that are going up to the brain. You're going to have some going out to the organs that are going to be controlled. There are some purely sensory things like the olfactory nerve. There is no motor neurons going to the sense of smell. It's just not there. We talked about regeneration, at least in the lab, I think it was. But once something gets cut, everything downstream is gone. But the Schwann cells will try to form a tube back and help this guy to grow back. And it can, but it doesn't necessarily happen. Okay. That's the same thing, just a different picture. Not a real good one. This is my go-to picture for the cranial nerves. And you can see that they're in number order 1, and there's 2. I'm not going to do this in order. There's 3, 4, 5, 6, 7, 8, 9, 10. And then there's 11, and there's 12. So they're all in number order going down there, except for 11 and 12. Showing some of the stuff. This is stuff you guys can do on your own. That's that cribriform plate. There's that olfactory bulb. There's the little nerves, fibers coming up through there. And that's just the sense of smell. And that is nothing else with that. The eyes with the crossover at the chiasma, going back to the back of the brain to be interpreted. I don't know why. Tried to draw with that one. That one didn't turn out good. Oculomotor, you don't need to know exactly which muscles it controls. Just know it controls eye muscles. Trigeminal, wait a minute, oculomotor, yeah, trochlea, also going to be eye muscles. Trigeminal CN5 is going to break into those three divisions, and you can see them right there. V1, and there's the V2, and then the V3. And a lot of the nerves are going to be, that's going to be a mixed nerve. It's not going to be purely motor. Number 6 is the last of the motor muscles for the eye. 7, the facial nerve. Let's see, yeah, I got it right there. It's going to innervate a lot of the same places that this guy does. Mostly muscles of facial expression, except for the chewing muscles. That's really all you really need to know about that. Cranial nerve 8, we did that when we were doing the ear. It actually breaks up into the vestibular and the cochlear. They come together and go all the way back. They just run together, so they're the vestibulocochlear. It's going to be balance in hearing. Uh-oh. No, why I don't have anything there. Number 9, glossopharyngeal mixed nerve. What the most important thing it does: taste, touch, pressure, pain from the pharynx and the back part of the tongue. The front part of the tongue is going to be the facial nerve. Cranial nerve 10, that's the one I told you guys goes everywhere, all the way down to the very bottom of the abdomen. It's an incredible one. 11 accessory is going to be that levator scapulae. It's going to sternocleidomastoid as well. It's going to help you turn your head and to shrug your shoulders. And then 12, hypoglossal. We test that by having the patient stick their tongue out and bring it in. And what we're looking for is the tongue should be in the center. If it's deviating one way or the other, something's wrong, either muscle or neural. And that's all of number 1. How you feeling about this one?
Pretty self-explanatory on most of the slides, I would say.
I think so. I think it's pretty straightforward. Okay, let's go. Well, let me get rid of that one and get another one up. And now let's share this one. Okay, as far as the spinal nerves, we have 31. This is a little bit different. I didn't really talk a lot about this in the lab, but there's some difference. You know, we only have 7 vertebrae in the cervical region, but we've got 8 spinal nerves. As far as the rest of these guys, they go right along with the number of vertebrae: 12 thoracic, 5 lumbar, 5 of the sacrum, because the sacrum is those 5 that are fused together, and 1 coccygeal nerve. The easiest way to say this, okay, we'll call that one C7 and T1, and this is going to really kind of explain this. So for C1 through C6, the C7 nerve is going to be the one above the vertebrae. So C1 is above C1, C2 above, so forth. C8 is below C7. And for the rest of the vertebrae, the nerve that goes with the vertebrae is going to be the one underneath it. T1 is below T1 vertebrae all the way down. So if you can just remember that little exception, you own that. Cranial nerves, the brachial, that's going to be the cervical plexus, the brachial plexus, the lumbar plexus, and then the sacral plexus. And these are going to disconnect and give rise to the named nerves like we saw in the lab. Ventral root or anterior root, motor, dorsal root, going to sensory. We're not going to go, I'm not going to put any anatomy on this test, but there may be some questions that are going to ask you something that requires you know where something comes from. The Ramey, see if I can draw this. Let's draw it out this way. Okay. And we'll call this the dorsal. These guys come together and form a spinal nerve. And a very tiny part goes out. And the biggest part goes this way to the front. And then this is one we talked about in the lab, the two Ramey communicantes. The furthest one out is going to be the white. They don't show it right there. It's that guy right there. That's the white. That's the gray. So the nerve, and this is all going to be coming from the lateral horn. This is going to be the nerves. They're going to go out like here, come back in. That's just the way the spine is, or the autonomic system is wired. We'll get into a little bit more of that on that last chapter. Nerve plexus, you don't have to know all of this. This is A&P lab. Now there's one that shows the phrenic nerve, but we won't worry about that. They've got all of these. Lumbar plexus, and on our lab list to see we had the femoral and the obturator nerve were the only two nerves coming from the lumbar. No, I'm sorry, that came from that is the lumbar. And then the sacral plexus and all that. That's kind of interesting. Here's something that's kind of interesting that you really need to know. There's such a thing called a dermatome. A dermatome, you know, we talked about all these different spinal nerves coming together and giving a name to them. Well, all those spinal nerves are going to have sensation for a certain part of the body, but they can also break it down by actual spinal nerves. And that's where this guy comes in. If you look at it, you can see the C2 is going to be in charge of sensation there. C3 is going to be like a turtleneck. C4 is going to be like a t-shirt. This is the way we remember it. T4 is the nipple line. T10 is the umbilicus. And these guys are kind of spaced out evenly right there. Now, when you get into the arms and legs, there's nothing, it's hard to do. You're not going to have to memorize this. Everybody, I carried one of these. It was on one of my little reference books. The thing about these dermatomes, and you probably won't see as much of this now because there's vaccines, but if someone gets chicken pox, later on that chicken pox, which lives in the dorsal root ganglion, can actually come back out and reactivate itself, but it will reactivate only on one dermatome on one side of the body. That T7 is where I had reactivation. I had shingles when I was in med school. But again, folks are getting chickenpox vaccine, and we've got two different shingle vaccines. That's kind of what it looks like. And this is following a dermatome on one side. Super easy. And chickenpox has always got those red papules with that white vesicle up there, or clear. Anytime they have a lull, it's something we have to expect to see in the testing banks. Hilton's law saying that the nerves that are in a joint capsule are also going to control the muscles and the skin over that joint. And it kind of makes sense because we talked about mixed nerves. So these nerves are really focused on areas, and that's all Hilton is saying. We talked a little bit about reflexes. There's two kinds of reflexes. Let's do this second one first because it's really super simple. A learned reflex is just something you learn from practice. Driving a car is probably the most common one. That's what we said. You can basically put yourself on autopilot, think about what you got to do or whatever, and you wind up, safe and sound at that place. And if something happens, then your brain will shock you out of that and you take over conscious control. So those are learned, whether it's anything that requires practice. The inborn, these things are hardwired into us. They are involuntary, but you can alter them if you practice. You can actually change those guys. Here's our reflex arc. I'm going to skip down to this one because it makes more sense. Okay, let's say that's the tip of your index finger. You reached into a drawer and there was a pen that was just the right angle. So that pain signal is going to go to this neuron, the first order. He's going to go to this neuron right here, the second order. Now he's going to send it upstairs, but he's not going to wait. He's going to send an immediate signal to the motor neuron saying, pull your hand back so we don't get damaged. Does that kind of make sense? It's pretty straightforward. Okay. There's most of the ones we talked about were the somatic. That's going to be our skeletal muscles that get turned on, and it's usually somatic sensory. The autonomic has its own reflexes. We'll talk about that in the next chapter. And that's just the reflex arc. We'll talk about some of those. The tendon reflexes, that's the one we talked about in class. That's just where the doctor strikes your patellar tendon below the kneecap and it causes your leg to come up because of the muscle spindles and the tendon organs. Muscle spindles are almost like muscle cells, but they're all about measuring the stretch and then sending the signal back to the spine. Tendon organs, same thing. They're wanting to let us know if our muscles are being stretched. That's a good one. It's showing how these guys will send their signals. And this is what we were talking about. The brain says this is how my muscle tone. So it's got the muscles stretched or contracted, rather, to a certain length. And if they stretch, that means they're no longer contracted the way that we want them to be. So we're going to have to bring them back into line. And by doing that, we wind up throwing our foot up. These guys only involve one synapse, and they're all on the same side. I know that the stuff crosses over during the decussation of the pyramids, but this is about spine. It's all on the same side. And there's that muscle spindle. There we are striking it. Now we're going to make it a little bit more complicated. Here's what actually happens. When that happens, then I'm going to tell the quadriceps to contract, because by pushing on it like that, I've kind of convinced the brain or the sensory nerves that it's no longer contracted the way I want it. To do that, I've got to contract the quadriceps, but at the same time, I have to send a signal to the hamstrings telling them I need for you to relax a little bit so that I can tighten up the quads. Does that make sense to you? Since these
Yes,
guys
it
are
does.
antagonistic.
Yes.
Okay. It gets even more complicated, but we'll wait for that. That's probably the worst part. So that one sensory neuron is going to actually talk to two motor neurons, one to back off and one to contract. Ipsilateral polysynaptic, because we need more than one neuron to do this. Same thing. This is just showing. I like this one a little bit better, but same thing. We accidentally touch something that's hot. We're going to get our biceps to pull our hand off, but at the same time, we have to tell the triceps to relax. Otherwise, we're just going to do this kind of quivering. Okay. Now, this is something kind of a special case. You walking along and you step on, say you're on a beach and somebody has a broken piece of glass there. You step on that broken piece of glass. So you're going to do the same thing. You're going to tell, on this case, you're going to tell the hamstrings to contract to pull your foot off of it. At the same time, you got to tell the quads to relax so it happens. But you've also got to send a signal to the other side, to the left leg, and tell it, I need for the quads to contract and for the hamstring to relax. They call this a crossed extensor reflex. Or even better, say you're right here, you're leaned over, you put your hand on something that's hot. If you jerk your hand off, then you're going to face plant on something hot. That's not a good trade. So what we do is when we flex to get away from danger, the opposite side has to extend so that we don't lose our balance. Honestly, that is the most complicated part. And it's kind of hard to see right there, but this is where we're going to talk to those same muscles, but we've also have to go across the great commissure and talk to the muscles on the other side of the body to get them to bear the weight so that we don't fall over. How's that one? That one's...
It's kind of the same thing. Eh?
Okay. Plantar reflex, this is one we use with babies all the time and with certain neuro patients. Now, when we get something and we rub it, we just, something not hard, we just bring it up the side of the foot and then come over this way. Normally, in an adult, all the toes are going to flex downward. That's just the reflex. Now, in a baby, when you do that, the forward toes are going to spread out. They're going to abduct, and the hallux is going to dorsiflex upward. That is normal for a baby because they are not finished having their wiring done. If you see that in an adult, it is absolutely abnormal, and they call that the Babinski sign. You'll see that all the time. This is one we don't do a lot. It's kind of invasive unless you have a reason, like someone has had a stroke. What you do is you just get something like a cotton swab, and if you run it along like this, the muscles are going to contract and it's actually going to move the umbilicus towards the same area. It's just one of those. And that's it. How you feeling about this one?
Feeling good. The only thing I had was if you could explain the first slide with like the C7.
Oh yeah, I can do that. No problem. Matter of fact, uh, let me get a blank slide. Okay. Okay. So there's, we'll do C6 and C7, so this makes sense. C6, C7 vertebrae, and we know the next one is going to be the T1. Okay, so C6 spinal nerve is above C6 vertebrae. C7 spinal nerve is above C7. C7 has two spinal cords around it. You also have a C8 right there underneath it. But all the rest of the way down, everything, so the T1 is below the T1 vertebrae, T2 below, all the way down to the L5, which is going to be below the L5 vertebrae. That's just, the cervical spine is just a little weird. The nerve that's called C1 through C7 is going to be above that vertebrae. And then you have the C8, and then everything else just falls into the regular pattern. How's
Okay,
that?
that makes a lot more sense.
I really don't think we'll have anything on that in the lecture. Maybe on the test. It depends on who makes it. They usually don't do a lot with that. Okay, let me get the last one up. Get this guy out of the way. Okay, 15 ANS. There's a little bit with this, but I will be able to get it. We certainly will. Let's see. Okay, let me get the pen. Okay, ANS, involuntary, not under conscious control, although you can do biofeedback and do this. So here's the somatic nervous system. That's going to be the motor neuron going to our skeletal muscles. These guys have got a lot of myelination. They've got a lot of those Schwann cells because this guy needs to be fast. Now, here's something else. It's going to use acetylcholine to turn on the skeletal muscles. Sympathetic nervous system and parasympathetic, these guys are going to have very light myelination. It's not as critical that these guys be that fast. Now, on both of these, the parasympathetic and the sympathetic, we're going to use acetylcholine as the first. Let me go ahead and kind of go through this. So I really can't go through that. I need to show you about that. We'll come back to this again. Let's don't go into this till we've done some groundwork. That's interesting, but not really very important. There's our main things that we want to remember. Parasympathetic is just housekeeping. That's just normal. That's sweeping your kitchen. Sympathetic is your house is on fire. So the parasympathetic is going to be very local in control. It's going to have the GI tract doing its thing, but it's not going to really have a whole lot to say about the rest of it. The sympathetic, if you're in danger, your entire body gets put on alert, and this guy is going to be that adrenaline rush that we have. Rest and digest, it's just the chilled out. This is the one that's going to be for the emergencies. So here's one big way to understand this. This parasympathetic is going to turn the GI tract on. You're going to have saliva, you're going to have the stomach, you're going to get the gallbladder, all of this. It's also going to be the one that's going to cause you to urinate. Usually, if you're chilled out, your pupils don't need to be really big. So, and also, you don't need as much air or as much oxygen. So you just kind of slow down the heart rate and the airways get smaller. In an emergency, those pupils open up because you need to see really good. You turn off the GI tract because that's no longer important. We just don't need to worry about that right now. The bladder's going to relax because we're not concerned about doing that. But we are going to open up the airways and we are going to speed up the heart rate. It's an emergency thing. If your house is on fire, you're not going to stop to sweep out your kitchen. It just makes sense. You need to take all those everyday normal chores and just set them aside until the emergency passes. Now, both the sympathetic and parasympathetic are involved in sexual response. The parasympathetic is going to be for the erection of the genitalia in the male and the female, whereas the sympathetic is going to control ejaculation and vaginal contraction. So these guys kind of work hand in glove with that. Basically, as a rule of thumb, whatever this guy turns on, this guy turns off, and vice versa. They're antagonistic. The parasympathetic is both basically going to come from the cranial and from the sacral nerves. That's where the parasympathetic, it's going everywhere, but that's where they originate. The sympathetic is going to be in the thorax and the lumbar region, so we call that thoracolumbar. There's an illustration of this guy, a lot of the cranial nerves, and then you get some of these, especially for the bladders and all of that, is going to be from the sacral. And same thing, just the difference. Basically T1 through L2. We've already seen this. We haven't got to the exact. Okay. Here's that sympathetic chain ganglia. So, let me get, there's the dorsal root. That's the, let me get oriented here. Oh, well, they got it over here. The white ramus, you see the signal leaving there, going in there, and then it leaves the white and goes into that sympathetic where there's another motor neuron. And then, so it's coming from the white, and then it's going to do a synapse on this guy, and then he's going to, it's kind of like a relay race. He passes the signal to him. He usually comes back through the white ramus, or excuse me, the gray ramus, and goes wherever it needs to go. And he can go out that same ventral ramus. He can go up or down. It's it's entirely possible for these guys to do that. So the white ramus is where he comes out. Now I need to go ahead and talk about this. So in the lateral horn, inside the spine, that's where we have the first motor neuron. He's going to go out. He's going to go through that white ramus, and he's going to come to a second neuron. So here's the thing on the ANS, they use 2 motor neurons instead of the 1 like we do in this guy. So there is that second motor neuron is outside the spinal cord. In these guys, looks almost like those dorsal roots. So we call this guy the preganglionic neuron, because remember, any neuron outside the CNS is in a ganglia. So that's the preganglionic. See if I can get that R closed. And this is the postganglionic. That's something we're going to need to kind of keep in mind when we go. Okay. We've already done that one. I think I've already done all. Oh, yeah, I did. I went the wrong way. Here's showing you how this guy's going. So he goes from there, goes out the white, synapses with this guy, and then this guy goes back into the spinal nerve and goes out to wherever he's going. It's on the same level. So if that were like T4, it's going out to T4. But he could also come through here, go out the white, and go up and talk to this guy in that ganglia, then come back in the gray and go 1, 2, however many levels up. And I need to tell you about this too. Let's go ahead and do this. Oh. So that is for the sympathetic nervous system. The sympathetic nervous system, you have this guy in the spine, and you have this guy in a ganglia, which is very, very, very close. And then this guy has a very long axon. So for sympathetic, you have a short preganglionic axon because these guys are close together. But the postganglionic is way longer. Now, for the parasympathetic, it's not that way. You've got a very long preganglionic. It turns out that those second motor neuron for the parasympathetic is very close to the organ. So he has a pretty short postganglionic. Is that making any sense?
It is, yeah.
Okay. It's just one of those things. The somatic reflex, the difference is in an autonomic reflex, you're going to have 2 motor neurons. That's the main difference. Something in the viscera is going to send a sensation. It's going to this first motor neuron, then to the second, and then out. Okay. Gastric intestinal reflexes, defecation, urination. The light reflexes, when you shine a light on a person's eye, the pupil is going to constrict. Coughing, swallowing, baroreceptor has to do with blood pressure. Those are all parasympathetic. Sympathetic, speed up the heart if the oxygen levels go low, open up constrict the blood vessels if the blood pressure drops. the reflex, and then we talked about that. Let's see. We've talked about that too. Okay. Neurotransmitters. We got to talk about this in the ANS just like we did in the PNS. And just like you've got two kinds, some of them are inhibitory, they tend to shut it down by hyperpolarizing, some of them are excitatory. Receptors, we already know about that. These are the only two neurotransmitters that we're going to use in the ANS. The ones that use acetylcholine, they call them cholinergic. The ones that use norepinephrine, adrenergic. Because, epinephrine, norepinephrine are generally, the trade names are adrenaline and noradrenaline. On the organs, you can have some of them that have cholinergic, some of them have adrenergic. The skeletal muscles definitely have cholinergic. They bind acetylcholine. If that wasn't enough, there are two types of cholinergic receptors, the nicotinic and the muscarinic. Nicotinic are always going to be stimulatory. Okay, this nicotinic is always going to be between the preganglionic and the postganglionic neuron. So whether it's sympathetic or parasympathetic, they all talk to the second neuron with nicotinic acetylcholine. Muscarinic, the muscarinic is basically going to be what the second neuron in the parasympathetic uses to talk to the organ, like the heart. This guy's going to use the muscarinic to tell the heart to slow down. I've got some good pictures there. The adrenergic, we've got alpha and beta. You may have heard of beta blockers. That's the one. The beta blockers, the beta are going to be involved with speeding up the heart and opening up the airway. So if somebody's got asthma, what we do is we give them something that acts like a adrenergic or acts like epinephrine or norepinephrine. And when it binds to it, it's going to tend to make the airways open up. In the lungs, the sympathetic is going to actually relax the smooth muscle so the airways open up. The thing that we use for this is albuterol. Alpha is involved with a lot of stuff, especially blood vessels. We'll talk more about that. Okay, here's where we get this thing. Don't worry about this stuff right here. That's not important. Nicotinic acetylcholine, everything uses it. Now, muscarinic acetylcholine is used by the parasympathetic. And here's another one that's weird. It's also used by the postganglionic neuron for the sweat glands. And we use the nicotinic acetylcholine on the skeletal muscles. So the easiest way to remember this is I use nicotinic acetylcholine everywhere, but I use it everywhere but the postganglionic parasympathetic, where I use the muscarinic, postganglionic sweat glands on the sympathetic, but most of the sympathetic is going to use norepinephrine on that from that second neuron to whatever it's doing. Is that helping a little bit?
It's a lot of days, but yeah.
Yeah, there's a lot on this, but if you just remember the exceptions, everything is going to be this except.
Okay.
That makes it a little bit easier. Nah, and you definitely don't need to go into the alpha and beta ones and twos. It's just not that important. Uh, this is that same picture, and again, they don't actually go with the nicotinic or muscarinic. Sympathetic and parasympathetic tone, just like we have a normal muscle tone with our skeletal muscles. Now, there's a couple of places that don't have any parasympathetic. It's sympathetic only. Our blood vessels is one of them. So if we want to open our blood vessels up and uh, lower our pressure or get more blood flow, then all we do is kind of back off on the sympathetic uh, impulses going there. So instead of like putting on the brake, it's more like letting off on the gas pedal, and you kind of slow down. So those sweat glands and the blood vessels only have sympathetic. So the sympathetic tone is basically going to be our blood pressure. And we need a little bit of blood pressure all the time. So if all of those guys opened up at once, we go into shock and die. So normally, sympathetic tone is going to be for the blood vessels. The parasympathetic tone is going to be for the heart. Unless we're doing something really strenuous, then we actually want our heart to go a little bit slower. This is an AMP2, but normally our heart, the pacemaker in our heart would beat at 100 beats per minute, but the parasympathetic almost always lowers it to 70 or 80. So those are going to be really going to be the thing for the tones. Uh, that's just the vasomotor. Oh, and the sympathetic also is the guy that's going to go to the adrenal glands and cause these guys to flood your body with adrenaline or epinephrine. And that's one of the reasons this thing is system wide. It also takes a while for it to come back in. People who've just been in a wreck or in some sort of stressful situation, they're just shaking, but it's not with fear. It's with that adrenaline that's still flowing through their vessels, and it takes a while for that to ease down. Um, the sympathetic is going to help us open up those blood vessels so that we can dump heat, like at this time of year. Um, Sympathetic or the epinephrine works hand in hand with thyroid hormone too. Which one lasts longer? Definitely going to be this guy because he's going to flood. He's not only going to release epinephrine from those nerves, he's going to go and just flood the blood with it. And we already said this is highly localized, but this is body wide. Hypothalamus, just what we said, controls this autonomic nervous system, and the emotions get in there, and that's why the emotions can cause us to sweat or for our heart to race, fear, things like that. We've got areas that speed up and slow down the heart using the appropriate nervous system. The blood pressure, temperature, water balance, all of this is really going to be able to. I don't think there's a whole lot in there that we haven't already talked about. And this really the last one. The biofeedback, I don't even know if they do that anymore. you can actually learn to control your heart rate consciously by being hooked up to a monitor that shows your heart rate. If you focus enough, you eventually can learn to control it. That's in itself may not be a bad thing for people, that we don't want to give beta blockers and slow down a person's heart unless, they're it's damaged and needs it. But especially for things like migraines or stress hormones, that wouldn't be such a bad thing. Well, any questions about any of this?
Honestly, not really. No.
Oh, okay. Well, I mean, that's it. That's all that we had left. With that, any questions about anything I can help you with?
Not right now, but you said like if like when I'm studying, if I just need to email you about something.
Shoot me an email. I'll check my email the rest of today and tomorrow, and Monday too, of course.
Mhm.
Oh, you guys can come in Monday afternoon if you want to, and I can help you guys with that if you're able to, around work and everything.
Mhm.
Okay, well, it's just me and you, so I'm going to stop the recording, but I will